Chat USMLE style question on type 2 hypersensitivity. Question. A 32-year-old woman presents to her primary care physician with progressive fatigue and jaundice over the past 2 weeks. She has no history of recent infections or medication use. Laboratory studies reveal hemoglobin 8.2 grams per deciliter, normal 12 to 16 grams per deciliter. Reticulocyte count 8%, elevated. Total bilirubin 4.5 milligram, normal 0.1.2 milligram. Direct Coombs test, positive. Peripheral smear, spherocytes without schistocytes. Which of the following best describes the pathophysiologic mechanism underlying this patient's condition? A. Immune complex deposition in small blood vessels. B. Mast cell degranulation mediated by IgE. C. Autoantibody mediated complement activation and phagocytosis. D. CD8 plus T cell mediated apoptosis. E. Delayed hypersensitivity reaction with granuloma formation. C. Autoantibody mediated complement activation and phagocytosis. Explanation. This patient presents with fatigue, jaundice, anemia, and a positive Coombs test, which is characteristic of autoimmune hemolytic anemia, a classic example of type 2 hypersensitivity. Mechanism of type 2 hypersensitivity. 1. Autoantibodies, IgG or IgM, bind to cell surface antigens. 2. This leads to cell destruction via opsonization and phagocytosis. Macrophages recognize FC and C3b on coded RBCs. Complement-mediated lysis, especially with IgM, antibody-dependent cellular cytotoxicity, ADC by natural killer NK cells. 3. In AIHA, IgG-mediated AIHA, warm agglutinin disease, seen in SLE, lymphoproliferative disorders. IgM-mediated AIHA, cold agglutinin disease, often post-mycoplasma infection or EBV. Coombs test detects these autoantibodies. Why not the other options? A. Immune complex deposition in small blood vessels. Describes type 3 hypersensitivity, e.g. lupus nephritis, serum sickness. AIHA is due to cell-bound antibodies, not circulating immune complexes. B. Mast cell degranulation mediated by IgE. This is type 1 hypersensitivity, e.g. anaphylaxis, allergic rhinitis. AIHA is IgG, IgM mediated, not IgE mediated. D. CD8 plus T cell mediated apoptosis, characteristic of type 4 hypersensitivity, e.g. graft rejection, type 1 DM. AIHA is antibody-mediated, not T-cell mediated. E. Delayed hypersensitivity reaction with granuloma formation. Granulomas are seen in type 4 hypersensitivity, e.g. TB sarcoidosis. AIHA does not involve granulomas. Key takeaways for USMLE. Type 2 hypersensitivity equals autoantibodies, IgG or IgM, against cell surface antigens. Hallmark conditions: AIHA, Graves' disease, Myasthenia gravis, Goodpasture syndrome. Mechanisms: complement activation, opsonization, phagocytosis, ADCC. Coombs test, direct test detects RBC-bound antibodies. Treatment: steroids, immunosuppressants, plasmapheresis, if severe. Would you like an